It's a great pleasure to be here. It's actually super to be back at Excel because I too was here for during 2012 Olympics and Paralympics. I was working as a venue medical manager, so I was here for 3 months. Didn't see a lot of daylight, did lots of pounding up and down the corridors, but delighted to say I actually had the pleasure of watching Martine playing for the British team, which was very exciting. So we're going to take you back, cast you back to the hot summer last year and just show a short video.
Cause you're a sky full of stars. I'm gonna give you my heart. Cause you're a sky full of stars. Cause you light up the park. I don't care, go on and tear me apart. I don't care if you do. Cause in the sky full of stars, I think I saw you. Cause you're a sky full of stars. I wanna die in your arms. Cause you get lighter the more it gets dark. I'm gonna give you my heart. I don't care, go on and tear me apart. I don't care if you do. Cause in the sky full of stars, I think I see
It now gives me the greatest pleasure to declare the 20th Commonwealth Games open.
The 25-year-old from England claims the first gold of the 20th Commonwealth Games. Hannah Miley, the champion in Delhi and the champion in Glasgow as well.
Games time has just been like it's been sprinkled with stardust. It's been brilliant.
It's been electric. There's something around every street corner. Glasgow is one of the best cities in the world.
Bring it on!
I work hard to be here and I'm proud to be a Clydesider.
I'm so glad I signed up for it 2 years ago. It's been an amazing experience.
I'm not from Glasgow myself, but I feel part of the Glasgow community now, which I never would have gotten to feel if I hadn't been part of the Games.
There are some cities, and I won't mention them, that are famous for dead things. But this is the place for live writing, poetry, rock and roll. It's buzzing, jumping, always will be.
I had the pleasure to be the General Manager for Medical Services and Anti-Doping and headed up the planning for the medical services. So both myself and John MacLean are going to just talk a little bit about what we put in place, what worked, what we learned, and how we can improve things as time goes on. A little bit about the sports. Before I start, I need to apologise for my voice. It wasn't the singing earlier. I'm hoping if I get through this, I'll be singing afterwards, so apologies for the croak. The great thing about Commonwealth Games is that they actually have some sports that are not usually at Paralympics and Olympic Games. And for those of you who know your sports and the eagle eyes amongst you, well, you know that we also have sports including squash and also lawn bowls, which are not usually at games. And this brings another dimension to the healthcare provision, because you've got to cater for those athletes and also the team officials. So in all of our planning, it was very much about the sports and the knowledge that we had from previous events as to how we were going to look after them and what we needed to put in place. One of the really exciting things about Commonwealth Games now is that we have the integration with the para-sports. So in Glasgow, we had 5 sports for athletes with disability. And this was immense to have athletes competing alongside those with a disability. So you would be watching swimming, and in one event it would be able-bodied, and the next would be athletes swimming with a disability. So it works really well on a small scale. And before we sort of start the debate of wouldn't it be wonderful to have Olympics and Paralympics together, it is so huge now, both Olympics and Paralympics. It works on a smaller scale for Commonwealth Games, but I think that's probably where it'll stay. It was across Scotland, so I'm also delighted to say, yes, all the main activity, and everybody knows it as Glasgow 2014. My home city is Edinburgh, and I'm delighted to say that we hosted the diving, and in Dundee there was shooting. So there was a spread across Scotland, so as well as being Glasgow Games, it was very much Scotland's Games. One of the things that worked so well was that the venues were already there, they were all finished in time, everything was smooth and good to go. And we knew that from a venue point of view, there would be no hassles. So what did we have to do? Looking back now, it was an enormous task, and the great thing is that it's now completed and we delivered. At the time, there were some really daunting moments, but our requirement was to put in place plans and delivery for all of the constituent parts who are going to be attending the Games. Whether that was the athletes, so 4,500 athletes, with their support staff, all of the media, all of the spectators, all of the workforce. So there's a huge number of people that we actually had to provide medical services for. We had to set up a mini hospital, which is known as a polyclinic, within the Games village where all the athletes live and sleep safely. And we had to provide medical services at venues, for training and at competition. And I'm sure a lot of you will be aware of the licensing around these requirements nowadays. So our plans had to be scrutinised at the highest level to ensure that we had the correct amount of medical care in place, whether it was for a performing athlete or whether it was for a member of the public. And so you never know how many people are going to be crossing those doors and looking and seeking help. You've got to just put in case to make sure it's provided. So what did we actually do? We delivered over 10,500 consultations. This was in a spread of over 25 days. As we had expected, 69% of that was to athletes, and 65% of those were in the polyclinic. So with our experience of previous Games, when we had actually been engaging volunteers to come on board, it was very much about saying, you'll be working with the athletes. And this was in fact proved correct. It's harder to motivate people if they think that they're just going to be working with some of the team officials, although we've all been team officials, they're very, very important. But the actual carrot to get volunteers is about saying, you'll be working with athletes, and percentage-wise, a lot of them did. I hope this slide is not too small for you to be able to have a look at some of the figures. A little bit of a breakdown of who we actually saw, whether it was an athlete, whether it was a member of the Games family. Now, this is somebody who has an accreditation and comes with the teams. It's not somebody's uncle or aunt. Technical officials, they also need to be supported, spectators and also the workforce. Along the top column, you'll see illness, new injury, not injured. Now, the not injured side of things, sport is now big business, and athletes come much better prepared, particularly, I have to say, in the UK, thanks to the UK lottery funding. But many, many athletes are now used to having actually preventative care before an event. So they would come in and ask in the polyclinic or in the venue for support, whether that's physiotherapy or massage, or they're looking for a doc to check their medication. But a lot of athletes now present non-injured, but the expectation is that they're going to have this provision of care. So, some numbers for you. We had 11 core staff, so I started 3 years out and appointed a fantastic team. We had quite a young team to start with, a little bit inexperienced, so the important thing when it came to actually the provision at games time was to bring on some experienced people. So we had a great number of fantastic people with experience. I have to say that because some of them are in the room. But we were very, very fortunate that we were able to supplement our young, inexperienced team with some fantastic provision of those who'd actually worked at games before. And following on from London had its pluses and minuses. Huge benefit in the public awareness, the excitement for volunteering. Some things also, our budgets were a lot less, and therefore the expectation was we had to manage expectations, what we were going to deliver. The background photo in this shot actually shows our MRI and our imaging facility, which was part of the polyclinic. Now, the framework that we were given to deliver from the Commonwealth Games Federation doesn't specify you need to have imaging services on site. However, we felt that it had worked so well in London, everybody expected it, and if we weren't able to deliver that, then it would be a little bit seen as the poor relation. So we managed the budget to enable us to bring on board Sheba, who then had all of the imaging services, and they were very well utilised at games time and made a huge difference to everybody. We had 1,400 skilled volunteers. Now, this is in a range of roles. So we had physios, we had A&E consultants, we had nurses, we had sports medicine doctors. We also had receptionists, we had first aiders. So we had to work with all of these volunteers coming from across the UK. We deliberately targeted the UK to ensure that we were going to get a real good cross-section of experienced people, but also that we would make sure that it was going to be business as usual for those supporting healthcare needs in Scotland. We then had to work with these people who would come in for 8 days over a 25-day period. So you never knew on what day who was going to be there and how it would work. A lot of the first 3 years was about building relationships, and it was about working with the stakeholders and ensuring that we had fully explained our plans. When we started, I think it's fair to say there was a little bit of a concern that the health service in Scotland was going to be disrupted by the games coming to town. So everybody was hugely excited about it, but what was going to be the knock-on effect of meeting targets? I'm sure a story many of you are familiar with. We spent a lot of time trying to explain that what we were putting in place would mean that we would ensure there would be business as usual in the health boards, in the NHS, and we were not looking to disrupt or ask for things, but we needed to have a stopgap if things didn't go to plan, if we needed onward referral, and John will talk a little bit about that in a minute. So we had a lot of engagement and really, really positive engagement with a number of organisations who really did all they could to help. I think one of my golden moments of the Games was actually the debrief with Scottish Ambulance, and the chap in charge there said, you know, we got there. We didn't agree the journey we were on, how we were going to deliver. We both had very good ideas as how it was going to work, and it worked so well. And he said, you know, we delivered. And that was just a golden moment at the end where we agreed that we'd had our differences, but we got there and we delivered well. One of the other important things to us was our medical advisory group, and many of you would have heard Sir Harry Burns talking earlier in the week about well-being. We were really lucky and delighted to have him chairing our group. And this group met on a regular basis. We put all our plans past them. They really scrutinised our plans, were very, very helpful. And we walked the journey with them, ensuring that they knew what we were about, so they could go back into their organisations and reassure them that our robust plans meant that we were trying to do all we could to make sure the games were a success with how we were going to deliver. When it came to the sort of final little end pieces where we were really desperate for some things to happen, then those guys who were on the medical advisory group really were able to pull out all the stops and get people to sort of come on board with this. So all the engagement that had gone very smoothly and nicely over the 3 years, the last few weeks was fairly frantic, but we got there, which was great. We also were extremely fortunate to have a superb group of clinical experts. This was something identified very early on that we needed. Talked previously about the Commonwealth Games Federation and their requirements. They require you to have an optometry system. They require you to have dentistry on site. So there are some disciplines which are invited into the party and others that are not. And that caused some consternation early on with other experts who weren't part of the named group that Commonwealth Games Federation feel that they have to have. We were extremely fortunate by those who were appointed as clinical leads, and the Games wouldn't have been successfully managed medically if it hadn't been for their enthusiasm, knowledge, and ability to coerce people to come on board and to support us. So it's a real big thank you to them. So my 3 months in London, it was a really fantastic opportunity in 2012, working for LOCOG on a seconded basis to actually plan what worked well, how are we going to then translate that into how we're going to deliver in Glasgow. And it's such a unique opportunity to actually have 2 games, major events in this country back to back. And so I was very fortunate of actually having the experience of then being able to translate that and actually change some of the ways we were going to do things, knowing that it had been hugely successful in London. We would have to do it in a different way because it's a different environment, different budget, different people. I think one of the examples was here in Excel, and for the control drugs, Excel, as you know, is made up of all these exhibition halls. Actually, weightlifting and powerlifting was on during the games here, which was a great stage for it. But in a temporary facility, which just has flimsy walls, control drugs need to be controlled. So what we had to do there was get a concrete block and to have a box, actually, a medical box drilled into the concrete to then control. And the Met Police had to come in and check that it was all into the concrete, it wasn't going anywhere, it was all locked and it was safe. So when we were reviewing this, thinking, how are we going to do things for Glasgow? Is there a simpler way of actually making sure that anybody who needed morphine or a control drug for real pain, how could we do this? So again, it was finding the best solution, and the best solution was working with Scottish Ambulance, who actually carry this all the time. It's controlled, and therefore in the venues, we didn't then need to go through the rigmarole that London had to put in, and it worked so well. It was just smooth and worked hugely simply, which was great. One of the other things that I felt was really important was about leadership roles. And London had so many fabulous volunteers who were all at the top of their profession. So you're faced with a room full of experts who are used to doing things their own way, used to doing a little bit of something but not following it through. So a consultant perhaps would prescribe something but wouldn't physically go and get it out of the cupboard. So our encouragement in London was, well, you can actually follow it all the way through. So I was knowing that in Glasgow we had to recognise that we've got a huge team of experts, but we've got to make them work together. So how is the best way of doing that? As was said in the introduction, I'm a physiotherapist, so I thought actually physios are pretty good at managing these situations. So we appointed a physio in each athlete medical room just to try and manage the flow so that everybody was greeted, everybody was then assigned to the best person to assess them. Everybody was desperate to assess the athletes. It was this huge enthusiasm that perhaps we don't see on a day-to-day basis in your environments. Perhaps you do, but I think from that point of view, we wanted to make sure it was really managed soundly. I've already touched on the fact that our framework was determined by the Commonwealth Games Federation and their CMO, Dr. Jager, who had to routinely develop, scrutinise our plans. What we wanted to put in place were robust plans that everybody could follow, knowing that we had 1,400 volunteers who were actually going to deliver the medical services, but they were only going to come in for those 8 days out of 25. So it had to be kept simple. It had to make sure that from all the way through, everybody could be delivering to the certain standard. One of the things we focused on a lot was volunteer training. As I said, that everybody had been appointed, all the volunteers, all the staff, on their expertise. So we knew we had fantastic people there. We knew that the clinicians were autonomous. They could do as they would do clinically on every day. So it was really about what does this mean working in Glasgow? What's the framework? What are the policies and procedures? So we had one opportunity to train these individuals, and it wasn't training them to be a nurse, a doctor, a physio. It was about saying, okay, how's it going to work in Glasgow? So we brought them together, and we put it a little bit like a multidisciplinary sports medicine conference, so that it was much more integrated. People who would be working together would be actually learning together. We went through a lot of scenarios that actually had been tried and tested. And there was an opportunity also of awarding CPD points, a reflective practice. So everybody at the end of their training opportunity felt that they'd actually had a good day out, as well as the fact that they were then okay to come and join us when it came to games time. So our new model of healthcare, picking up some of the points I just made, I'd like to say it was probably, I feel it's the Scottish model. It was very much value for money, and it was very simplistic. These were some of the things that we did. It was about working. One of the most exposed areas for any sports event is extrication from the field of play. And I think all of us have seen the funny videos when a stretcher is going off, pull it one way and one the other. And of course, if you're responsible for that team, then it's the worst possible thing that could happen. So we wanted to make sure that that was as slick as possible. And again, knowing Scottish Ambulance do this all the time. So let's work with them to ensure that athletes are extricated as slickly as possible. And that worked really well. We've talked about the controlled drugs. We also minimized the medications that were available. Again, cut down on choice to make sure that we had a huge spectrum, but it was less than they had for Olympics, and I think that worked well. And one of the other things we had was a recovery centre within the polyclinic so that athletes could focus on recovery as well as getting any treatment that they needed. So a little whiz through those. I'm going to hand on to John now for some of the specifics.
Thanks, Liz, and good morning. It's a pleasure to be invited and a pleasure to be here. As the chairman said, my name's John MacLean. I've been a sports medicine doctor in Scotland for longer than sports medicine doctors have actually existed, I think. And it was my honour to be the Chief Medical Officer for the Commonwealth Games. Just before I start, I wrote down in a bit of paper, listening to our fantastically inspiring previous speaker, respect, trust, commitment, communication and diversity. And I think Martine illustrated how these are the necessary qualities in order for elite athletes to work together and to be successful. And I think these are principles that Liz and I took on with our team and with our clinical experts in planning for the Games. And I think these are things that really we all work towards in trying to be the best we can be in life. Before we started, one of our clinical experts was Richard Budgett, who was the Chief Medical Officer in London 2012. And asking him for some advice, he said, the two key things are to plan for the inevitables. You guys have been to major games, you've planned major events before, so you know what's coming up, you know the things that you need to do. But much more importantly, try and predict the unpredictable. And one of our key unpredictables was, as you can see in the slide, was our organisation and our working with colleagues in public health and our concern of the possibility of having an outbreak of infectious disease. As you'll know, working in healthcare, health boards and health authorities are very good at pre-planning for major events. And in Glasgow, we were lucky to be involved very early in that planning process with Greater Glasgow and Clyde Health Board, with Scottish Government, with Health Protection Scotland, and with the Environmental Health Department of Glasgow City Council. And they were fortunate to invite us. I was embedded within their planning group and then within ours. So really from 2.5 years out when I joined the organisation, we began to look at the planning for what might happen and what did happen, as I'll show you as we go on. The second thing we did, as you'll see on the slide, is that we were lucky to have seconded and embedded in our core team a public health consultant. And ironically, she wore two hats because as a Greater Glasgow Clyde Health Board employee, she'd been involved in the planning team process, and then when she came over to work in us was our key link, which was absolutely vital in our outbreak, as I said, I'll mention in a second. Those of you that follow the Olympics and the Commonwealth Games will know that the Olympic torch, or in our case, the Queen's baton, goes around all the competing countries. So we again engaged very early with our infectious disease colleagues in Glasgow who were involved in giving us some input and training to our volunteers who would follow the baton around the 71 territories and nations of the Commonwealth. And we had a relationship with that department which was to prove vital when we started having patients requiring admission to hospital. And the final thing is that the Commonwealth Games are different from the Olympics, and only 1/3 of the teams come with a team doctor. The other 2/3, we were responsible for all the medical care. Some would come with physios, some would come with neither doctors nor physios. But what we did, we had a requirement through General Medical Council licensing to engage with these team doctors early, but we piggybacked on that, building a relationship with them individually, on the telephone, by email, or some of them were able to come from the bigger nations and visit us in Glasgow, and we could show them our plans. So I think it was really key to getting that engagement because we required that relationship and engagement when it came to managing infectious disease later on. One of the things that we learned from London was the importance of data recording, and it was one of our biggest issues in planning to get the IT system right, to be what we wanted it to be and to report in the way we wanted it to report. So we had, as you'll see on the slide, a fairly robust medical encounter system. Liz mentioned over 10,500 medical encounters, and all of these were recorded in real time or very shortly afterwards, which gave us an at-the-minute picture of athletes or staff presenting with illness or injury. And let me give you an example of how that helped. We had a number of venues within Glasgow and out with. So if our venue medical manager noted that there was one athlete in the Nigerian swim team, for example, not a real case, just an example, who had diarrhea, that wouldn't particularly flag up any red flags for them. But if a similar Nigerian athlete had diarrhea at Hampden at the athletics venue and 2 at the mountain biking and another 1 at squash, our system was able to give us in real time the fact that 5 athletes from the same team had flagged up with a similar illness, which meant that we didn't have to wait until the 11 o'clock at night or the 7 in the morning formal reporting times. We got live active data that would allow us to act as soon as. And we had with our venue medical managers a very experienced person in each venue, and their job, their task, as well as organising the staff and providing the service, was to be our first pair of eyes for disease surveillance. The remainder of the teams, as I've said, were looked after by us, and that gave us an additional problem because we had to ensure that, particularly for infectious diseases, those athletes and team staff were willing to come forward and tell us. Most of us who work in healthcare are used to patients presenting because they're concerned about their illness. Within sport, their priority is to be able to compete. And perhaps all of our fear in planning was that athletes or team staff would not be willing to come forward, perhaps under the apprehension that we would prevent them from competing because they had a diarrheal illness or a respiratory illness or whatever. So we had to try and build that trust and relationship with the athletes and with their team staff, even if they didn't have doctors or physios with them. As Liz mentioned, we were monitored by the Commonwealth Games Medical Commission. We both attended an early morning meeting with them. We had a later in the morning 10 o'clock teleconference where Glasgow 2014 presented our surveillance data, Health Protection Scotland presented the national and international picture of infectious disease, and our colleagues from the local health board and environmental health gave us the picture of what was happening in the city. So between these three groups, we felt that we managed to put that jigsaw together, that we were well aware of what the picture was, and that working relationship, again built up over many months and years before the Games, was to prove vital. There's a graph there just showing some of the surveillance data that we picked up, and you'll see there was 4 key infection-orientated pieces of data: rash and fever, GI, respiratory disease. And you'll see that's over the 25-day period. So from our opening of the polyclinic, not all of the teams and countries were in at that stage. Not surprisingly, you'll see the build-up over the period of the Games and then a tail off towards the end. And again, respiratory disease perhaps being our biggest. We had a norovirus outbreak. It's often said in the media that when there's a quiet news day, the media will look for stories. And those of you who have never been to Glasgow, well, I'm delighted to tell you that the weather in the summer is always spectacular. So we had temperatures in the 20s for the 4 or 5 days before the opening ceremony and in the first week of the Games. The athletes were beginning to arrive. The press and the media and the public were expecting the Games to begin. So, to be honest, our friends in the media had very little but positive messages to put out there until the shit literally hit the fan. And what happened is we had a norovirus outbreak. All of us are healthcare professionals. We know that the people who look after these outbreaks are us. There is a very well tried and tested procedure for doing that. And Liz and I's main thrust in this whole thing was twofold. One was to try and persuade the non-healthcare people in our organisation to let the people who do this for their day job manage the outbreak. Yes, Liz and I could bring a Games perspective and perhaps bring a slightly different level of urgency for individual athletes or potential people affected, but it really was business as usual. That's what we'd planned for. That's what our colleagues had planned for. And with respect to the media, to try and dampen down their sometimes overinflated stories, as I'm sure we realise there is. Our key concern was to protect our athletes and the support staff that were there to help, to enable these people. Martine spoke about, for her, it's a twice in a lifetime, maybe 3 times in a lifetime opportunity to compete at a major Games. For a lot of our athletes, it was very much a once in a lifetime. And to have trained for 4 years and then find because you had diarrhea, you couldn't compete, would have been a disaster for them. It turned out that the outbreak was confined to an external group of workforce. It was security, people from an external contractor. And we did have an issue, and again, it's not for making a particular point, but these individuals were in low-paid jobs who were only paid for the days that they work. So one of our concerns would, despite our best efforts of ourselves and our colleagues, would these individuals come to work who were symptomatic in order not to lose their day's pay? So you can imagine it was a fairly fraught 2 or 3 days for us. It was very early mornings and very late nights. It culminated in the unfortunate appearance of us on television and on radio, trying to give the organising committee's view, and I think we managed to do that successfully. One of our challenges was the multiple agencies that were involved, although one of the successes was the multiple agencies that involved. But perhaps the media parts of these agencies having to agree a joint statement, and that took most of the days on most of these days. So our teleconference at 10 ended up with 4 or 5 teleconferences until finally everything was agreed and done and dusted. And Liz and I were key to that because our expertise in Games and our medical knowledge could back up what our clinical experts and our colleagues could do. So we took it based on expert advice. We put in the appropriate public health measures within the village and within all areas of contact regarding cleaning, etc. We put a pretty robust process of educating village residents, of speaking to team doctors, of us going to the 7 o'clock meeting in the morning with the general team managers. We impressed the importance to teams who had and hadn't medical staff that we would visit athletes in their accommodation rather than then coming to the polyclinic. And as Liz mentioned, our admin staff, who were our front line in reception, being aware of the importance of infectious disease, asking the questions early. We had a triage room immediately at reception, but we did try and encourage the athletes to stay at home, and the appropriate measures regarding cleaning, isolation, not going to the dining room, etc. And the importance of that trust and relationship, because the athletes want to compete. And we've both been there as team medical staff, and we know that we want our athletes to compete for themselves. So getting that relationship with the team docs and physios to say, look, trust us, we will do our best to enable your athletes to compete. Don't keep that information to yourself. And you'll see that our press handle these things differently. You'll see the top right, the broadsheet in Glasgow, the Herald, had a fairly bland headline. The Record, a tabloid, a bit more hard-hitting. Norovirus hits 48 people at the Games Village. And as you know, the incidence, the number of patients will increase until it peaks and then go down. So for that 24, 48 hours of the numbers peaking was when the greatest pressure was on us to supply. And you'll see, with no disrespect to the Sun, they probably got the message over in a different way. We had a second issue to contend with, and I wasn't privileged to be here early in the week to listen to colleagues speaking about Ebola in West Africa. It was something we were well aware of, both from the Queen's Baton relay with our staff going to countries that were affected by Ebola, and also the potential of athletes coming here. And we took a lot of advice. We spoke a lot to the team doctors from these countries. And obviously we had a concern for those athletes who may have come with Ebola, given the period before the symptoms appear, and also the potential knock-on effect for the people living with them in the village. So our plans beforehand were increased training of our staff on Ebola particularly, but infectious disease in general, and a very low threshold of awareness. And as you'll see on the slide, we did have two cyclists from Sierra Leone who were admitted to hospital with a fever with no obvious cause, and were admitted pretty quickly, very efficiently under the infectious disease control, ambulance transfer, etc. Needless to say, the press also caught up on that, and one of the athletes told his story about the panic of being admitted. Now, you know, we all know that an infectious disease or a potential disease such as Ebola is obviously treated with utmost severity and utmost precautions. And we had a great relationship, as I've mentioned, to enable that to happen. And we were able to reassure the other teams that these athletes had been admitted very quickly, and the risk to anyone else in the village was as low as we could possibly make it. I'll pass on back to Liz.
I think just on the Ebola one of the challenges we do have working in healthcare is about confidentiality. And both of those two incidents were very, very well managed, but it was the sort of need-to-know basis that we struggled with. Everybody wanted to know everything, which was totally inappropriate, and we spent a lot of time trying to manage that as well. Picture up there for you was of the polyclinic. It was in the heart of the village. We had a fantastic facility. It was a temporary facility, but it worked well for our needs. It also shows you it was a 24-hour operation. We were emergency care throughout the night and primary care, whereas during the day it was physiotherapy appointments, optometry, dental, and pharmacy, imaging again going through the day. We also provided a wheelchair and prosthetic repair service, and those guys did a fantastic job, particularly some of the countries who came with wheelchairs that really our guys in Britain wouldn't even entertain. So it was really seeing what we could do for them while they were actually competing at the Games. So it was a short-lived. Was it unique? Well, it certainly lived in Glasgow for 25 days. The great thing was that everybody wanted to support the athletes. So there was no, well, I'm not doing it, it's your turn. It was everybody actually wanting to look after everybody who came in the door. There was no competition for resources. They were all available to everybody. We did prioritise on medical need, but we then also, as the games went on, had to prioritise on competing athletes. Because there is sometimes a tendency is, oh, well, I'm here anyway, perhaps I should get this checked out. And that's fine, and we had the resources and the time to do that. However, we needed to make sure that those who were competing had priority. I think everybody talks about communication and the importance and the challenges across the organisation. We had a number of different people doing different things on different days. So whether we used the newsletter, real-time, mobile phones, radios, it was a huge challenge to ensure that people were informed, and particularly challenging with some of the things that were going on with some of the healthcare messages we were trying to put out to ensure that everybody was actually kept abreast of this information. John and I were sort of holed up in what was the FACC, the Functional Area Command Centre, and literally sort of didn't see daylight for a few days while we were trying to work on these couple of incidents that came through. But when we came out, everybody was smiling, looking after athletes, and we knew that the plans that we had put in place were being effective. John's going to run you through one of the case histories just to show how we illustrate the things that happen at games.
We've just put this up as an illustration of how we felt our services provided a good service. And you'll see on the slide the case we're presenting of a male badminton player from the Falkland Islands who actually turned out that he had an injury before he came to Glasgow and had been treated by his own team medical staff, assessed, and still travelled a very lengthy journey, as you'll know, to Glasgow for the Games. He was seen in the polyclinic the day after he arrived, assessed by our sports medicine staff, physio and sports medicine doctor, who were aware of the significance of his knee injury, unfortunately. His knee was swollen, it was unstable. And the beauty of the system was that these individuals, the physio and the doc, were working together, unlike sometimes within health services where they're in different places and don't have the opportunity of examining together, discussing the case together. They spoke to the athlete and the team manager. They didn't have medical staff with them, and it was decided quite rightly that they would be referred for an MRI. They walked 10 yards round the corner, got an MRI slot pretty quickly, and that was reported instantaneously. So again, we're not trying to challenge health service, and we know we've worked in the health service for almost all our lives, all our working lives certainly. So we're aware of the fact that we were in a privileged position that we were able to do that for those 25 days. But it did show a fantastic example of joined up healthcare, where we could sit down with that athlete immediately afterwards, with his team manager, with the sports med doc and the physio and the radiologist, given the results, unfortunately, that showed that he had a significant knee injury. He was unable to compete in the Games. He was offered the opportunity to go and have a consultant orthopaedic opinion, which he did a couple of days later, and the decision was made that he would return to the Falklands, and then, as you can see in the slide, he came back to Scotland and had his operation done under the Falkland Island government 6 months later, and is well on the road to recovery. So just a small example of how, for that athlete, although he wasn't able to compete in the Games, it was part of the wider picture and what we were able to do for our medical services. Last couple of slides. We did have to change. We set out our ideas and our principles, but if we'd been very rigid to that, we wouldn't have provided the service that we think we did at the end. So we had to realise that we had to listen and we had to change. We had a very good managerial system within the polyclinic with 3 very senior managers with different skill sets and different backgrounds, including Mark, our pharmacy manager, who is in charge of organising this whole conference this week. So we had a bit of time before the soft opening when the team started to arrive. It was very tight because the polyclinic was one of the last buildings that was up and running. We used some experience of previous people that had been at previous Games to perhaps streamline the system that we had planned. As Games went on, we realised it was better, for example, for the dentists to make their own return appointments rather than coming back to a central desk. So we really were conducive to listening and changing as long as it fitted in the general pattern and provided as best a service as we could. It was about a dynamic assessment, a team assessment, the opportunity for things like MRI as we showed. But our MRI machine broke down for 24 plus hours. So we then had to adapt. We had to use CT more. We had to use musculoskeletal ultrasound. We had to prioritize, as Liz said, the competing athletes, and others who would have got access to the scanner had to wait until we caught up a couple of days later. And no one was unable to compete or unable to get treated because of the lack of that, because we were adaptive to change. And the last thing was communication, both within the polyclinic, with the staff, as Liz mentioned, the constantly changing staff, and also the fact that we had to speak to team doctors. And we had a couple of occasions where team doctors were demanding in the nicest possible way services that were out with our remit to provide. But what we could do in that is say, well, it's not core service for the Commonwealth Games, it's not even our larger core service for Glasgow 2014, but we'll put you in touch within the private sector in Glasgow with a consultant who can potentially help you for that particular procedure. So always adapting, always changing, always hands-on, and hopefully always effective. And you can see just briefly there the spread. Remember, these are 3/4 of the 10,500 consultations that took place, 3/4 of them in the polyclinic, and you'll see 1/4 sports massage, 1/4 physiotherapy, 1/4 in the immediate care, A&E and general practice, and the rest spread out through some of the other disciplines. But huge numbers. If we look briefly at the type of conditions, not surprisingly, 68% were musculoskeletal. And of the contact injuries, the traumatic injuries, half contact and half non-contact. We did have data from London. We had some data from Manchester Commonwealth Games, but really at the beginning when we were planning based on the knowledge we had ourselves and the data we could get from other people to give us an idea of how many consultations potentially we would have. We did have some challenges. Our leadership, as I mentioned, within the polyclinic was excellent, and that really got the staff through those days, particularly with so many members of staff changing in very many days. Our volunteers, our 1,400 volunteers, were supplemented by contractors, for example, from Toshiba, who brought their own technical staff. So it was trying to integrate them within the team and trying not to detract from the fact that one small group were getting paid for their job and the rest were there as volunteers with no money and still having to provide their own travel and accommodation to the Games. As Liz mentioned, we prioritised athletes within the polyclinic. Our processes were dynamic, they were reassessed, and we had a daily briefing at the beginning and the end of each shift as to what went well and what we could change. It was a temporary building, it was completed late. We did have some issues, as we would have with IT, but we overcame them. And we overcame them largely because of the willingness of the volunteers just to do that little bit extra to ensure the data was on, that we could have that reporting system. And we coped with the breakdown of the couple of bits of equipment. And I think my final slide is an illustration back into healthcare. As Liz mentioned, the main concern from the health authorities in Scotland, from government level to local health board, was how would the 1.1 million ticket holders impinge on the local healthcare in Glasgow? How would our 6,500 athletes and support staff, plus Games family, plus media, impinge on the local healthcare? How would our demands impinge on what was being provided? And I think, as we mentioned, half of our volunteers came from out with Scotland and half of the Scots came out with Glasgow. And of that group of local volunteers, perhaps only half or 2/3 of them worked in the health board. So that initial fear that all of our volunteers would take away from members of staff over a busy holiday period when people are looking to take holidays over the beautiful Glasgow summer I mentioned to you earlier. We did have good support. We had relatively small number of admissions. We had single figures over the course of the whole Games. But our key, I think, is the top bullet point there, is that we identified early. I'm a local GP in Glasgow, and I know sometimes it can take me 10 minutes on the phone to get through to speaking to the right person when I'm referring a patient. We had a single clinical manager in Greater Glasgow and Clyde who was unfortunately on for 25 days, 24 hours a day. We had 2 equivalents within our Glasgow 24 team who were on a shift system, and they were the single point of contact for all matters related to hospital admissions. So, for example, the person with a query Ebola, our person, our single point of contact, would phone Anne in the hospital. She would then speak to the infectious disease. She would organise the hospital transport, etc., so that we weren't having to make 4 or 5 phone calls. She would coordinate the discharge. She would coordinate the visits from the team doctors or team staff. She would speak to Liz and I about the importance of us going, visiting, and us letting the Commonwealth Games Medical Commission know. And it worked really, really, really well. And the bottom bullet point, they also provided us with appropriate laboratory services and a beautifully streamlined system. And again, these 2 clinical managers we had took full responsibility for all results management, because the doctor that ordered the blood glucose at 2 o'clock in the afternoon when the result came back at 5 was off shift. So our clinical manager took responsibility so that for continuity of care, we had no problems.
I do have to point out that the sun also shone in Edinburgh. So finally, what do we actually consider were the quality indicators for our success? First of all, we had a shared goal. Everybody wanted to be there. They wanted the games to be a success. They wanted the athletes to produce their best ever performance. It was a shared vision. Nobody wavered from that. We had a huge support and a robust structure with our stakeholders. We knew that we had this strong supporting cast who would be there if we needed them. The expectations were clear. We had a mass of volunteers, individuals, fantastic staff, fantastic volunteers. They all knew what they had to do. They were actually empowered to do that. And finally, there was a fantastic buzz around the games, and we delivered. Thank you for your time.